Good morning, sir. Can I know what's your name and your age?
I'm Mark Sloan, I'm 30 years old.
Where do you live at and what do you work as?
I live at Lelina Street and I'm a carpenter.
Okay, what are your complaints today? How are you feeling?
I feel pain in the abdomen, at the right part of my abdomen.
Do you have anything else to add? Like, do you have vomiting or weakness?
No, but the intensity of the pain is low and it is reduced when I bend forward. I often feel weakness and fatigue when I stand up, and I always feel thirsty but I have no appetite.
Okay. Can you tell me what the color of your stool is?
My stool is in dark color and was repeated in watery color.
Now I'm gonna check for your vital signs and let me examine you. Okay, so let me check your blood pressure and your pulse. How is it? Blood pressure is 100/60. Is it normal, right? No, it's not normal. You have hypertension, so I can just conclude that for now. Okay. Your respiration rate looks abnormal. You have tachypnea and tachycardia. We need to examine your stool. So can you give us a sample of your stool in this bottle? Yeah, sure. Okay, thank you. Okay, now we have the stool sample of Mr. Mark, and now we are going to examine the stool.
The lab test done shows that the patient has anemia. The circulating blood loss is 1,500 ml, which falls in the class 2 category. The red blood cell count of the patient is 2.5 million per cubic millimeter.
Hi, I'm Dr. Muiz. So based on the lab result we obtained from the patient Mark Sloan, so he have a low level of hemoglobin, which is 7 mg per deciliter, and our target is to raise up to 14 to 18 mg per deciliter. And for his red blood cells, which is 2.5, and our target is to raise up to 4.6 to 6.2 for the period of 3 to 4 hours. And then for the hematocrit, the level is 0.30 and our target is to raise up to 0.45. Okay. Okay, sir, for the fresh frozen plasma, I will give you a short brief what is FFP. So basically, this is indicated for patients with a coagulopathy who are bleeding or at risk of bleeding, and therefore we use it for the management and prevention of bleeding. So for this case, the Mark Sloan, our patient is in an emergency situation. Okay. And for the indications, for your information, the risk of transfusion will be moderate due to his duodenal ulcer. Why moderate? Because if the patient undergoes without transfusion, the chances of success is 0%. Therefore, by using transfusion, we will have a slight chance of success. And don't worry, we as physicians will try our best for this matter. Okay. Since the patient Mark Sloan has a blood loss of 1.5 to 2 liter, so basically we will use a few planning volume, and then for the first part is dextran 40 for 1.5 liter, and the reason why we use this is because we want to improve his blood flow in the microcirculation. And the second part we will use crystallite, which is normal saline, for a volume of 1 to 1.5 liter. And for the third one, we use the FFP, which I explained before, fresh frozen plasma, a volume of 250 to 500 milliliter as expected, and the PRBC, which is packed red blood cells, also the volume of 250 to 500 milliliter as expected. Okay. I have one question for you, and may I know if the patient Mark Sloan has a medical history such as diabetes mellitus?
He does not have any medical history.
Do you have any questions for me?
Since you explained very well, so I don't have any questions for you.
Okay, thank you.
Now gently shake the porcelain spot blade and wait for 10 minutes. Here's an image where you can see agglutination in A, B, and D spots in the porcelain spot plate, which then gives the blood group as A, B, positive. The positive denotes RH positive.
Good morning, madam. How are you today?
Morning, doctor. I'm not getting better.
So today I will start administering IV line, intravenous line, nasogastric tube and urinary catheter. Is it okay for you?
Okay, doctor.
Dextran 40. It is a sterile, non-pyrogenic preparation of low molecular weight dextran in 5% dextrose injection or 0.9% sodium chloride injection. It is administered by intravenous infusion. It is indicated for use in the adjunctive treatment of shock or impending shock due to hemorrhage, burn, surgery, or other trauma. Total daily dose shouldn't exceed 2 gram per kg or 20 ml per kg of body weight. If therapy continues past 24 hours, don't exceed 1 gram per kg, that is 10 ml per kg daily. Continue for no longer than 5 days. About 50% of dextran 40 excreted in urine within 3 hours, 60% within 6 hours, and 75% within 24 hours. Remaining 25% is hydrolyzed partially and excreted in urine, excreted partially in feces, and partially oxidized. Normal saline solution, that is crystallized solution, it is given to balance the electrolytes deficit in the body. Its initial volume replacement in ratio 1:3 of predicted blood loss. Fresh frozen plasma is a blood product made from liquid portion of whole blood. It is used to treat conditions in which there are low blood clotting factors or low levels of other proteins. It may also be used as a replacement fluid in plasma exchange. 45 to 70 mg per ml is used. 10 to 20 ml per kg of body weight will increase the factor level by 20 to 30%. The number of units used is desired dose in ml per 200 ml per unit, 10 to 15 ml per kg IV initially, administered via infusion set with filter, not to exceed IV infusion rate of 1 ml per kg per minute, and 4 units are given. RBC given when the hemoglobin concentration is lower than 7 to 8 gram per deciliter. The recommended IV dose is 10 mg per kg body weight as bolus followed by 1 mg per kg per hour infusion if bleeding continues. About 250 to 500 ml is given to the patient intravenously. 1 unit of packaged RBCs should increase levels of hemoglobin by 1 gram per deciliter, 10 gram per liter, and hematocrit by 3%. 1 unit contains 300 ml. Patient will be given 5 units to recover 1500 ml blood loss.
From 10 a.m. to 2 p.m., we administer every 1 hour volume dextran 40 250 ml, normal saline 250 ml, frozen fresh plasma 200 ml, and packet red blood cell 300 ml.
And why we stop at 2 p.m. because after that we will achieve a normal value of lab result, and the solutions continue to be given until lab result, which are the hemoglobin of 50 mg per deciliter, and our target is to rise at 14 to 18 mg per deciliter. For RBC, which is the value of 5, and our target is to raise up to 4.6 to 6.2, and for the hematocrit, the value is 0.45, and our target is to raise up to 0.45.
Vitamin K. Phytonadione is to administered intravenously, diluted in 50 ml of normal saline solution and administered over 60 minutes. Phytonadione is never given IV push. Vitamin C. It is given once a day at noon. Aminocarboic acid. It is a derivative and analog of the amino acid lysine, which makes it an effective inhibitor for enzymes that bind the particular residue. Such enzymes include proteolytic enzymes like plasmin. The enzyme is responsible for fibrinolysis. 5 gram in 250 ml solution is given over 1 hour. Each subsequent gram 50 to 100 ml at 1 gram per hour. Continue after about 8 hours until bleeding is controlled. Calcium chloride. The usual adult dose of this preparation varies from 5 to 10.
Medication part, during transfusion, we will also use these 4 medications to enhance the replenishment of blood in the patient's body until 2 p.m. For the first part, we use vitamin K, which is given to the patient of 2 milliliter for every hour till 2 p.m. And second is vitamin C, is given 1 milliliter once at 12 p.m. And the third one is aminocaproic acid, is given about 50 milliliter for every hour till 2 p.m. And last is calcium chloride is given 1 milliliter at 11 a.m. till 2 p.m. And the reason why we use peripheral venous line because there will be a low of risk of irritation and blood vessel damages.
Here is the chart of the lab result of the patient. We can see that there is the decreasing amount of value of hemoglobin, hematocrit, and red blood cell in the beginning of the treatment. During the treatment process, these values are begin to increase, showing the patient is successfully receiving good response to the treatment. The patient is getting better. In conclusion, we can see that the patient is getting better from the vital sign that is being recorded in this chart. At the arrival time, 10 a.m., the patient is having tachycardia, but begin to show the decreasing value during the treatment. The respiratory rate also showing that the patient is having tachypnea at the arrival time, but begin to decrease in value during the treatment. Together with blood pressure also showing that the patient is better because the arrival time the patient is having hypotension but begin to increase until it's become normal. The consciousness is 14. The temperature of the patient is high in the beginning of the treatment but begin to decrease during the treatment process. The skin of the patient is dry from 10 a.m. to 3 p.m. but begin to become moist because we have give the fluid treatment to the patient.
Since there was no activity of the GIT, we kept patient at 2 NPO, and to maintain the fluid balance, we administered 2400 ml of finger selected solution.
Expectation for patient to urinate for 1 hour is 70 ml. After 3 hours, which is 4 p.m. until 7 p.m., we can see that the collected urine output is 200 ml per hour, showing the patient is getting better as he is giving response from the fluid treatment.
We choose to administer combination of normal saline and dextrose 5% solution, and we administered 2400 ml of solution in this manner. We'll do another follow-up examination at 3 o'clock and 9 o'clock respectively, and all the parameters seems normal and the urinary output is also normal. There is no signs of complication. We continue to monitor the patient in the interval of the 6 hours. The patient conditions are improving. Right now the pulse rate of the patient is 76, the respiratory rate is 18, the temperature is 36.9. The skin and the mucous membranes looks moist and the consciousness is 15 and the blood pressure is 120/85. So the diet of the patient can be changed to clear fluid and the NG tube can be removed and the urinary output has also increased. But we will still continue to administer the fluid through the IV line, but the amount is reduced to 1000 ml, and we administer 500 ml of normal saline at 9 a.m. in the morning and 500 ml of dextrose 5% 7 in the evening.